So I'd like to welcome you all to the Fall 2020 OLLI Medical Series. This is a weekly class, 1 week in the morning, 1 week in the evening. This used to be done in person at both the Fullerton Elks Club and the Morningside Retirement Community, but because of COVID, we've gone to being online. So tonight, the doctor is Dr. Verikaman Grandjian, who's an internal medicine specialist and gerontologist at St. Jude Heritage. And there he is, with a background in healthcare research and policy. Tonight, he'll be talking about hypertension, which is a problem particularly related to heart problems, stroke, diabetes, and obesity, and endocrine problems, all of which occur more frequently in the elderly population. He'll talk about some of the medical treatments, the diagnostic studies, and complications of this very serious health condition. Okay, so doctor, if you would like to go ahead.
Sure. Yeah, thanks everyone for being here tonight in this remote sense. Thank you for that nice introduction. I'm Dr. Chris Verikaman. I'm a full-time clinician with the St. Jude Heritage Providence Medical Group. My practice is in Yorba Linda, and obviously as a general internist and primary care physician, I every day treat hypertension and more importantly have conversations about hypertension, because treatment goes far beyond just prescribing medications when it comes to hypertension. It's really important. So I'm going to go through a presentation. I anticipate it'll take somewhere 45 minutes to an hour, depends how many questions we get. I do encourage people to ask questions in the chat or jot them down so you don't forget, because usually there are a lot of questions about how to manage hypertension. I know my patients always have really good questions, so I'll try to share those where I can. So let me get my slideshow up here and we will get started. Management of hypertension in the older adult. Older adult has become kind of the preferred term when we're talking about so-called geriatrics or elderly populations. Obviously, there's a lot of words that are analogous to one another, but older adult essentially means there's no hard and fast definition. In geriatrics, honestly, we don't really start thinking of patients as being really geriatric until they reach age 85. However, given your overall health, you may you may be more, we'll talk about frailty, and those of you who are at my talk this weekend, we spent a lot of time talking about frailty, but depending on what's going on in your life, you may face very similar challenges regardless of your chronological age. So these issues should be pertinent to all of you who are interested in learning about them. I don't have any financial disclosures. I don't take money from drug companies. I don't meet with drug companies. Just so you know, this is all based on my own, training and practice. I guess I should mention, I was trained both med school and residency at the University of California, San Francisco. I did a chief residency there and spent a lot of time both research and clinical with the geriatric faculty there, which is one of the leading departments of geriatrics in the country. So I was very lucky to take some of these lessons from here. Unfortunately, also one of the best departments of cardiology and nephrology in the country as well. So I learned about hypertension from a lot of people who know a lot about it. So I'll try to bring some of that here today. So I think it's important to always run through an outline. What are we going to talk about, and then we'll review at the end. I think it's really important to understand, what does hypertension mean? What is the difference between hypertension and just having a high blood pressure when you go to your doctor's office, or when you check at home on your cuff, or check at the drugstore when you're waiting to pick up your medications or what have you? And give hypertension some credit. I think sometimes in medicine, certain diseases get a little bit more cachet because they're more exotic or quote unquote more interesting, but hypertension is a very complex physiological and pathophysiological condition, and there's a lot we still don't understand about it, and this plays into how we treat it, because we have to oftentimes be very creative in how we manage hypertension and make sure we understand what's causing it. We'll talk about how to diagnose it the proper way, Why it matters, in the intro kind of said, but hypertension in and of itself, oftentimes you don't feel it, but over time, over months and years and decades, it can cause a lot of internal damage to important structures in the body, blood vessels, and by extension, organs like the heart, the brain, the kidneys, um, and other blood vessels in the body, like in the arms and legs. And because of that, we really need to identify it and treat it aggressively as early as possible, to maintain good health and functioning later in life. We're going to start at that point. We're going to launch into non-pharmacologic treatments, because I think if you talk to any of my patients who I manage, my preference is really, let's max out what we can without medication before we start putting you on medications, because those habits that it takes to manage hypertension are important habits regardless of what medications you take or not. Although many people with hypertension will need to be on medication at some point in their life, and that's okay. The medications are important and they're helpful, but I think it's very important to have a good foundation of non-medication treatment for your blood pressure. And then we'll finish with some of the more, I think, current and pertinent questions as it relates to treating hypertension in older adults, which is, what is our goal in terms of what are we reaching for in terms of numbers, and why, and what are the trade-offs that come with trying to treat hypertension more aggressively, and should we be doing that or not? Okay. I always try to include some funny comics in my talks because the material can get a little bit dry. It's just poking fun at stress tests. This would probably elicit a similar effect. So I think it's while cruel, not a terrible idea. So we'll start with defining hypertension, which is obviously important. The most recent guidelines that we're kind of going by came out in 2017, so about 3 years old now. And they sort of simplified the definitions of hypertension, which I think is important. We used to have this idea of, oh, this is stage 1 or grade 1 hypertension, grade 2, this is severe, this is pre-hypertension. I think it overcomplicated matters. And like most things in medicine and in biology, there are no hard cutoffs. Any cutoffs we impose are somewhat artificial. And so are these. So if your blood pressure is above 130, and a diastolic above 80, then by definition you have hypertension. And this is again, this goes along with trying to diagnose it early and treat it aggressively early. However, within that, there's a lot of nuance, obviously. One of the most important ones when I'm seeing patients is I want to make sure that what we're dealing with really is what we call primary or essential hypertension. This means just a time-dependent and sort of, dependent on a lot of things, but over time, the body's usual mechanism to maintain blood pressure is distorted either by, we talk about things like obesity, diabetes, salt intake, life stress, whole bunch of things. And it starts to get skewed, and it starts to produce a higher blood pressure than we really want in terms of keeping the other parts of the body healthy. Whereas secondary hypertension, this is hypertension or high blood pressure due to some other medical cause. And it's really important in certain cases, in particular when we have hypertension that's really, really hard to treat. We have a patient who's being so adherent to their diet and not eating too much salt and eating very healthy, keeping a healthy weight, not smoking, all the things, and yet we still have them on 4 or 5 medications and it's still not well controlled. That's when oftentimes we need to think about going and looking for a secondary cause, and we'll talk about some of those things. And just to reiterate, why do we do this? Why do we care? Especially if you can't feel it when your blood pressure's high a lot of the time. It has a lot of downstream effects on your body. It increases your risk of heart attack, increases your risk of stroke, increases your risk of having poor circulation in your extremities, like your legs, especially when combined with other conditions like diabetes or cigarette smoking, a heart failure, heart not being able to pump as well as it once did, and all the things that go along with that. So it really does matter, and it's really an important thing that we do in primary care and internal medicine. I only put these pictures up just to hammer home the point. This is complex. I'm not going to walk through all of this. This is not a scientific talk, but it's to put to the point that that anyone who thinks hypertension is sort of simple or not interesting, I think, is kind of missing out on a really fascinating illness. It's regulated in the kidney. It's regulated by your blood vessels, by your heart, by your brain, by your nervous system. It really is a multi-system disease, and that's why my main point is that's why treating it requires multimodal treatment: diet, exercise, lifestyle, medications of different types that block different parts of the pathways that lead to high blood pressure, because just pushing on one button doesn't have a whole lot of effect on the whole web. It really is a whole and complete kind of approach to an attack for treating hypertension. I always like to do this when I'm teaching like my PA students from Chapman, or when I was teaching med students up in San Francisco, and really going to like, why does this matter? Why does the body need blood pressure? What is the point of blood pressure? Well, blood pressure is really important. That's how we ensure that the flow of blood, which carries oxygen and clears out wastes and brings other nutrients like sugar and protein to our cells. We need to make sure there's enough pressure to get the blood where it needs to go, to the brain, to the kidneys, to the muscles, to the heart, to the liver, et cetera, et cetera. And so the body, through evolutionary processes, has adapted a way to maintain blood pressure through a fairly tight range of possible pressures, but of course it can be deranged over time. Obviously, if you eat a huge salty meal and you draw more fluid into the vessels, to the pipes, so to speak, your blood pressure will go up. If you're dehydrated, your blood pressure might go down. And then your kidneys and the rest of your body will react in a way to raise your blood pressure to get it back to normal. So we're making sure we're getting blood to the important parts of our body. Things that you take, whether medications or supplements or food like caffeine, that rev up your sympathetic nervous system, which is, is kind of your, it's a bit cliche these days, but your fight or flight nervous system. So too much activation of that system will cause high blood pressure, or not enough activation of its sort of its mirror image, the parasympathetic, which is the so-called rest and digest part of your system. Not enough activation of that system can certainly lead to derangements in blood pressure, among many other things. Renal function, chronic kidney disease, hypertension is a huge component of treating chronic kidney disease, and a huge problem and a big contributor to excess and early mortality and morbidity, so to speak, in patients with chronic kidney disease, heart failure. It depends on so much, and so many things can affect blood pressure. But what I like to do is to acknowledge that this is complex, but let's make sure that we understand that there are some basic guiding principles in terms of how blood pressure is regulated and how it can be dysregulated that help us understand how best to treat it. One thing we do know is that over time, if you eat an excess of salt, which to get to specific definitions, it's hard. Generally, we think somewhere between 2 and 3 grams of salt a day is about the maximum. Sodium a day is about the maximum that we want people eating. Now, one thing I always say in these talks, and I'll say again in this talk, is if you prepare your own food at home, it's from scratch ingredients, it's pretty hard to overeat salt, even if you're salting while you cook or you salt your food. The problem overwhelmingly that I see with my patients in terms of salt intake has much more to do with either eating prepared food or prepackaged food, like frozen dinners from the store, pre-prepared meals from the store. Because salt is a great preservative, and it helps food taste good. So that's usually where we get in trouble, and that can be something to tweak if someone's having a hard time getting their diet squared away and their blood pressure. It's a vicious cycle with kidney function. As your kidney function decreases, it disrupts part of the control mechanism for blood pressure, raising it, which further damages the kidneys. So that's very important in terms of thinking about how we treat it and how to protect kidneys, because kidney function obviously is important, and it helps stave off the end stage results of renal disease, which in the last stages can require a decision about whether to start replacement therapy with dialysis, which is always a big conversation and a big decision for patients. And then you can also have, like I talked about, secondary causes. So some of these really important ones that we look for are what's called a renal artery stenosis, which means essentially that the vessels leading to the kidneys are all clogged up and narrowed up. So the kidneys on the back end, much as you would if you had if you have a clogged pipe in your house, you would see very little flow through that pipe, and you would think, oh wow, I'm not getting anything. So the kidneys react by raising blood pressure, which then compounds the problem. Sometimes people are born with problems that where the kidney produces too many chemicals that raise blood pressure. Hopefully we diagnose this early in life, but I got to be honest, sometimes we don't find this until later in life, which is unfortunate. Or you can have these very rare tumors that can increase adrenaline, which raises your blood pressure, as you might imagine. Those are the kinds of things we typically think about. And I only bring that up for patients who might, either yourself or someone is on 4 or 5, even 6 maybe agents for blood pressure and still having a hard time controlling it. I had a patient with this problem, and he ended up having renal artery stenosis. So it's really important to keep this in mind, so you can ask your doctor or your nurse practitioner or your physician assistant, whoever you see for your primary care, if it's something you need to be concerned about. All right. So now we kind of talked about what hypertension is, both in terms of the numbers that define it, as well as kind of some of the things that can lead to it. But how do we actually diagnose it? Because as many of you might have experienced when you go into your doctor's office, sometimes your blood pressure is high, or sometimes it's fine, and sometimes it's not. In the old days, we used to work with a definition of 2 elevated blood pressures on 2 separate visits, at least 2 weeks apart. As you can imagine, that's not a very precise way to diagnose blood pressure. And I think for a lot of reasons, that's why we moved away from that. First things first, if someone has a high blood pressure, what I'm going to do is obviously I'm going to talk to you, and I'm going to look at your history and try to find things that may be contributing to sort of up the probability that what we're seeing is true blood pressure. So if you had for older adults, family history isn't necessarily as important, but certainly if your parents or your brothers and sisters or other family members who are closely related to you have hypertension, there's some genetic susceptibility, as there are for virtually all the diseases that we try to treat in medicine. Are you overweight? Are you obese? Are you a smoker, a cigarette smoker? Do you drink more than a moderate amount of alcohol, or even a moderate amount of alcohol? Alcohol can have direct effects that raise blood pressure. Are you on other medications that might be raising your blood pressure? Is your diet heavy in salt, or is it interacting with other medical problems like diabetes, where your diet is contributing to poor diabetes control and potentially worse hypertension? And then your life, your environment, your social situation, these all do matter. There's this concept of so-called allostatic load. This is basically all the things you have to carry around with you every day as you live your life, especially in the time of, the coronavirus pandemic. I've seen a lot of patients really struggle with this, both through things like weight gain, or they picked up smoking again, or they're drinking more, or just feeling the kind of the weight of the world on your shoulders. And that can certainly contribute to harder to control hypertension. So it really spans a large number of underlying potential causes. The secondary ones, just say that there are special tests for them, and talking to your provider about that is kind of step one, and then it's up to them to know what to order or to ask for help if they're not sure. So after we kind of go through the historical things, looking at old studies, old tests, looking at old trends, things like that, if I really want to know if someone's hypertension and it's not clear, they're not checking themselves at home, the gold standard is and remains what's called a 24-hour ambulatory monitoring. This is a pain to do. You essentially put a blood pressure cuff on with a little, pump and a recording device. And about every 2 minutes for a 24-hour period, this cuff goes off and takes your blood pressure. Obviously, it's a generalization. Different machines may work differently, but in general, that's how it works. And this is really important because it illustrates the point that blood pressure really does fluctuate throughout the day, and a given day may be totally different than another day. When your stress hormone secretion by your brain tends to be higher in the morning or the mid-afternoon, blood pressure tends to spike. It tends to be a little bit lower in the mid-morning or before you go to bed. If you had a stressful day, it might be higher. If you had a really nice day, it might be lower. If you exercised, it might be lower that day. If you haven't exercised in the week, it might be higher, and so forth. So from that 24-hour monitoring, what we get is we get an average. And the average is really what I care about. I always tell my patients, your blood pressure will fluctuate. And obviously there's sometimes even the fluctuations are too much. But in general, I want to know where you're averaging out. And that's what we can get from 24-hour monitoring. As a replacement, and personally, what the guidelines recommend, and I totally agree, is we've really moved to home monitoring as sort of the best approximation of the gold standard. So this means having a reliable cuff at home, which these days pretty much anything you can find in the drugstore or from a reputable source, unlike Amazon, is going to be reliable. And this is what I encourage my patients to do. I say, please take your blood pressure, not 8 times a day. That's not necessary, but once, or if you feel like it, twice, but once a day is fine. Just make sure you spread out the times you take it. So if you take it at 8 o'clock one day, take it at 3 o'clock the next day, and then take it before bed, and then take it, at noon, and then do that for a few weeks so we can get enough data. And then, what I do with my patients, I just sit down and put them in a spreadsheet, and it spits out an average number. And if the average number looks okay, then we're doing okay. And I much prefer that to looking at the very few office visits that we get. I don't know how useful it is to go off that, in particular if, we're getting a reading at your dermatologist where you're waiting to find out if your skin biopsy was cancer or not, or something like that, right? Like obviously you're going to be fairly stressed at that point, and that may manifest in the higher blood pressure. White coat hypertension, which is that idea of your blood pressure is higher when you go to the doctor. It's interesting. It's not totally benign. White coat hypertension does actually correlate with regular hypertension. That's why I really want my patients to check at home. And what we find is often they do agree, although I do have patients who are much, much higher when they come to the doctor, and then I get their home readings, and they are fine. So it does exist, but it's not totally benign. It's not something that's totally just write off. And then some people have the opposite, and this is why home monitoring is really important too. They are fine when they come to the doctor, but at home they run much higher, and I've seen this too. So that's why the upshot of all this is it's a really good idea to get a cuff, one that you can afford. You don't have to get the crazy expensive one that has all the bells and whistles, just something that'll do the trick. And keep track of it from time to time, and share that with your doctor at your physicals or at your follow-up visits, because that's the easiest way for us to make decisions about what's best to do for your treatment. Hypertension is exceedingly common, in particular people over the age of 75. This is from this sort of yearly study that we do in the United States of a bunch of different health things. 3/4 of people or more have or will develop hypertension. Rare is the patient who doesn't have hypertension into their 9th and 10th decade of life. Part of that is genetic jackpot, but for the most part, those patients also lead very healthy lives in terms of the lifestyle things we're going to talk about. It can develop at any time. This is a progressive and chronic illness, so it's always disheartening, and I totally understand when I have a patient who's never been on any medications, but then, they get to age 80 or 85 and all of a sudden blood pressure is running high. And it matters. And I'll share some data with you that show it does matter even treating it at that age, especially if you're in good health and you're living independently and want to stay that way. If you or a loved one or a sibling was diagnosed in the childhood years, unfortunately, a lot of times, I'll see patients like that who have never really been worked up for a secondary cause. And that's important to do because obviously we always want to treat the underlying cause in medicine. So what do these numbers mean? This is something that I think oftentimes we as physicians or advanced clinical practitioners forget to really highlight. So these are pressure readings. I don't know if you might have some mechanics or engineers out there. And of course, there's a million different units to measure pressure. We use millimeters of mercury. And the pressure reading on top was what we call the systolic. That is a combination both of what we call the sort of systemic vascular resistance, which to put in lay terms is sort of the resting tone of all the blood vessels in your body that sort of manage blood pressure. So that can be high or low or normal. The systolic, the reason it's higher, this is what we call the pulse pressure, the difference between the two. And this is when the heart is actually contracting and squeezing blood out into the vasculature. And so it obviously that top number is going to depend on a lot of things: how strong the heart is contracting, how well it's filling, and then how squeezed the blood vessels are, either because of medications or because of stress, or, you know, like you were bringing up, is it just that there's a lot of calcification in the arteries, so they can't really expand to deal with that extra volume, so it raises the pressure higher, a condition we call isolated systolic hypertension. The bottom number, the diastolic, what it's telling us, this is kind of your resting tone or squeeze. This is how tight the vessels are at any given time. Now, if your vessels are really calcified and they can't really squeeze anymore, that's when we can see the diastolic number actually go low. And it's very interesting. A lower diastolic is better until it's not. And it sort of gives us what we call this U-shaped mortality curve. And it's something we see in public health and epidemiology. It means if your diastolic's high, it's not great. As it goes lower, it's awesome. Your risk of, at any given point, more death, mortality from any cause goes down. But then as it starts to get really low, it starts to creep up again. And that catches a lot of people, both who just have a lot of vascular or atherosclerotic disease, meaning a lot of plaque and narrowing, or people who have heart failure or other conditions that can cause that number to be low. So to sort of summarize and put not too fine a point on it, the difference between the numbers really represents how well your heart is working, how hard it's beating. But part of it is really how squeezed down your vessels are. And that's what's going to be important when we talk about treatment with medications. So to Ms. Broom's question, isolated systolic hypertension, it is a very common finding in older adults. In fact, I'd say it's more the norm. And it's exactly what you described. It's a high number, it's a top number, the systolic number that is higher than 130, can be as high as 160 or 170, with a totally normal or even low diastolic number. And this is challenging to treat because most of our medications work by, in part by relaxing or dilating, we say, blood vessels, which is going to make the diastolic number go low. And sometimes that causes problems. We'll definitely dig into at the end of the talk, orthostasis and increasing frailty, that are very important to take note of and avoid in older adults. So, and what I like, and the reason I like geriatric medicine, is that you really have to know the underlying principles in physiology, but you also have to spend a lot of time talking to your patient, because you have to come to a sort of happy medium about, you know, not over treating to the point that the patient doesn't feel good and is miserable, but also, you know, being really clear that we're trying to prevent bad things like strokes and heart attacks, which can really, you know, obviously rob you of a lot of your independence and functioning. So like I said, isolated systolic hypertension is a starting point, not an ending point. And we look for ways that we might be able to manage it without causing too many problems and side effects down the road. Just a plug for us primary care physicians. I'm not an anti like Google or WebMD. I will say Mayo Clinic tends to have the best sort of like layperson outlines of common health things. So I always try to steer my patients to them and away from like WebMD and Healthline, which I don't always find to be helpful. But this is kind of our role to sort of take these principles and guidelines and try to figure out a treatment plan that works for you. You know, I have a patient, she's in her late 80s. She's very healthy, but she was on a couple blood pressure medicines when I started taking care of her, and she kept falling and passing out because her blood pressure would go too low. So now we accept a higher overall blood pressure, similar to the numbers Ms. Broom shared, because on balance, it's much worse for her to be falling in the bathroom at 3 a.m. and hitting her head and, you know, bleeding all over the place, having to go to the emergency room, which is what was happening on an almost monthly basis. So I just use that example to say this is what, you know, ideally a good primary care provider, whether a physician or a nurse practitioner or a PA, this is really what they should be doing, is being able to balance all these things beyond just the simple numbers. The numbers, again, they're the most basic starting point. They are not the end point, and they are not the goal writ large. So on that note, I want to start talking about, okay, once we've identified it, what do we do about it? Well, my general preference is, you know, and this is in the patient who's otherwise healthy, hasn't had a bunch of heart attacks, doesn't have heart failure, doesn't have, you know, cirrhosis of the liver. Very different in those patients. We're going to be a lot more aggressive with medications because we have to be in those patients. But if you are starting to develop essential hypertension and we picked it up and diagnosed it, what do we do? Well, like I said, I like to really push to start non-pharmacologic approaches to treatment. So diet is huge. The one with probably the best data for it is the DASH, or the dietary approach to stop hypertension. DASH diet, tons of stuff on the internet. I usually there's a particular PDF handout I like to print out. It's from the Mayo Clinic that I give my patients. It's a very common sense diet, and that's why I like it. It's not overly prescriptive. It's eat a lot of fruits and vegetables. Get enough protein. If you were at my talk this weekend, we talked about the importance of protein in the diet, and really limit starchy carbohydrates, dense sugary foods. And I'm not saying never, I'm just saying not every day, or maybe not in the quantity that you typically eat them. And also really important, limiting the salt, which we see at the bottom, but that's part of the DASH diet, is salt limitation. Some people have medical conditions that require them to go even lower on their salt, less than 2 grams a day. Like I said, somewhere between 2 and 3 grams of salt. Just to give you an idea, if you get a can of like Progresso or Campbell's soup, eat the whole thing, which isn't that hard to do if you're hungry, that will provide you over 2 grams of salt. So that's it. You're kind of done for the day. So that's a good illustration of how pre-prepared foods really can get you in the salt. They are convenient, and, depending on, for folks who live alone or may not have a ton of help at home, doing things like meal prep, totally understandable. And that's where we can talk about strategies like emphasizing lower sodium options of those kinds of food, or planning the meals of the day so we don't go over on salt. The Mediterranean diet, similar to the DASH diet, just in its general structure, it's a little bit more prescriptive in that it really emphasizes the fat sources being from so quote unquote, this is where I think what popularized the term healthy fat. So Mediterranean diet would be like unheated olive oil, the fat from like fatty cold water fish like salmon, nuts, olives, just plain olives, and emphasizing things that theoretically they eat a lot in the Mediterranean, right? And it definitely has data for it, especially when it gets down to the content of the fatty acids that people eat with it. It's a little bit more prescriptive. Not everyone likes eating this way or finds it appealing. So I tend not to prescribe this one in the sense that you have to do this. I like DASH because it's a little bit more flexible and you can fit in things you like. New and kind of exciting areas are, and it's something you may be familiar with, and I'm not advocating for ketogenic diet or fasting, but there are some very interesting sort of basic science studies showing that ketogenic diets might have a positive effect on a lot of the risk factors for heart disease, both lipids like cholesterols, blood pressure, and then intermittent fasting, which is this notion of limiting your intake of food to a set time either per day, or having a day or two a week where you eat a lower number of calories than you typically would otherwise. These have to be individualized decisions with both your physician or your provider, and then oftentimes a consultation with a dietitian can be helpful too, because the best diet is the one you're going to stick to, honestly. You don't want to go gung-ho on something that's not going to be sustainable, but diet really does matter, and it's really one of the foundational pieces of managing blood pressure without using medications. I should also say alcohol, for a lot of reasons, I never tell people to teetotal or totally abstain, but for certain patients, limiting intake might be really important because it can raise blood pressure. And if you're an everyday moderate drinker, which after the age of 65 for everybody is 1 drink a day, stopping drinking or cutting back can have a significant impact on your blood pressure, 5 to 10 points off the top in some cases. So it's not a trivial thing. Stop smoking. There's so many reasons to stop smoking. Hypertension is one of the big ones. Nicotine directly raises blood pressure. And then there are other nasty chemicals in tobacco smoke that also can cause downstream effects that raise blood pressure. Exercise is awesome. There was this great article in the New York Times a few years ago that was so true, because it said exercise really is the miracle drug, and it is. And the great thing is exercise, even if you don't lose any weight, I think a lot of us take up exercise because we want to lose weight. It doesn't always happen because most of the weight loss has to do with diet and the calorie intake. But even if your weight stays the same, the value of exercise is huge. You can knock 10 points off your systolic blood pressure just by exercising 20 to 30 minutes a day. And I'm not talking about going to the gym and lifting heavy weights or running on the treadmill. This is a brisk walk. This is a brisk walk around the neighborhood. And if you don't do anything, start with 10 minutes and work your way up. There's no reason to feel like you have to go from 0 to 100 on this. But really 20 to 30 minutes every day, or if you go 4 days, about 45 minutes. What we're shooting for on a weekly basis, and this is one thing that Kaiser really popularized that I think was great, was 150 minutes a week. So that's 30 minutes 5 times a week, and that's why I say 20 to 30 minutes a day if you go every day. And it's the equivalent of like walking. So not running, not sprinting, not rowing, not CrossFit, just walking. If you do lose weight, it helps too. Obesity, for a lot of really interesting reasons, has direct effects on raising blood pressure. If you can lose adipose tissue or fat tissue, you can lower your blood pressure. Again, a weight loss of 5 to 10% of body weight. So if you weigh 200 pounds and you lose 10 pounds, 10 to 20 pounds, which is not trivial, but can be done. It's doable. Again, you can knock another 10 points. So I can take someone who had a blood pressure. I had a patient like this, had a blood pressure when he came to see me of 160 on average-ish, and he lost weight. And he wasn't a smoker, but he was diabetic. He got his diabetes under control. He lost weight. He started exercising. I was able to take him off his blood pressure medicines. And not every physician necessarily is open to that, and there's reasons for and against it. I come down in the camp that if someone can get their blood pressure under control without medications, for reasons we're going to see when we talk about side effects, I'd always prefer that. Okay. So now let's jump into the meds. These next set of slides, we're going to walk through these are going to be the most common things we use to treat blood pressure. Are there other things that we use in very specific disease settings? Absolutely. I didn't get into that. And I tried to keep this very much as focused on what really matters to me and you. How do they work? Because that's going to lead to us how we think about side effects. And what are the pluses and minuses of it? And focused on older adults. So the first class, and the reason I put this first is because by and large, it's what we like to start with in many cases, are diuretics. And diuretic just refers to urinating a lot. And so theoretically, these drugs work by not so much making you urinate a lot, but by not letting your blood reabsorb sodium. Salt, sodium chloride, table salt. Water follows salt. Salt is like a water magnet. And wherever salt goes, water goes. So if you reabsorb too much sodium, you also get too much fluid back into the bloodstream, and that can raise blood pressure. The ones we use for blood pressure really are going to be the thiazides, which are like hydrochlorothiazide, chlorthalidone. I'm sure some of you are on one of these medicines. And then I also included the so-called aldosterone antagonists, spironolactone, triamterene. There's a couple others, but those are the big ones here, because that's really why we use them, for their effect on salt. And one thing I do want to make a point of is these are not like, if any of you take Lasix or furosemide, these are not loop diuretics. And loop diuretics don't really have a huge impact on blood pressure necessarily. And they also have a lot of other side effects because they're a potent diuretic, whereas thiazides and aldosterone antagonists, especially at the doses we like to use, not rarely, but typically do not cause a lot of volume loss. And so we don't worry as much about things like either dehydration or sometimes more annoying having to go to the bathroom all the time. But some people do experience that. So, and I've been humbled by that as in the time I've been out of training and in the real world where people tell me. Why are these medicines good? They work. They've been around forever. They're cheap. They have side effects, but we know about them, so we can monitor for them. And monitoring usually just means, getting your blood work done on a fairly regular basis with your doctor. The downsides are kind of what I already said. One, in general, it can lead to dehydration or urinating a lot. And obviously, if you're getting up at night to go to the bathroom, that's a fall risk. And among other things, you're not getting good sleep. But in older adults, the other problem that I often see with these medications is it actually lowers your sodium. And in younger folks whose kidneys are just younger, that's not really an issue because they have a lot of machinery that's there to sort of fine tune the sodium concentration in the blood and keep it in a very tight range. But as your kidneys age and you lose, you know, what I tell my students, functional units of the kidney, the nephron. But as you lose functional parts in the kidney, all of a sudden you start to lose that ability to fine tune sodium. And so if you're taking one of these medicines and you're urinating out sodium, sometimes the sodium in your blood can actually go low, and that's a problem. If it goes too low, it can cause seizures and coma and all sorts of bad things. Typically, you'll know because you'll start to feel more tired, or your family might notice you're more confused, or you're kind of, you know, not making sense, or you're weak and not getting out of bed. Those are all kind of signs of it, and those are things I always have my radar up for my patients who are on these medications. Okay, the next class that often we'll start with, and is a perfectly fine thing to start with, and that's one thing I'm also going to try to talk about, is things that make sense to start with and things that do not make sense to start with. ACE inhibitors, these are like your lisinoprils, your enalaprils, your capta, anything that ends in a pril is going to fall in this class. The ACE stands for angiotensin converting enzyme. I'm not going to get into the details of what that means, but essentially what it does is it prevents this enzyme or this piece of machinery from converting a chemical into its active form that, among other things, causes blood vessels to squeeze. So it causes blood vessels to relax, and that will lower pressure because they're more wide open. These medications, they work really well. And they have this added effect just by virtue of how they work, that if you're already having some hypertensive, what we call hypertensive kidney disease, like protein in the urine, things like that, this can actually prevent that from getting worse and can give your kidneys time to heal. So in anyone who has evidence of that, or certainly anyone who has diabetes and is at higher risk of chronic kidney disease, this is usually what we'll reach for first. The cons. Because they cause vasodilation, they can lead to orthostasis, which we're going to talk about more at the end, but it's essentially that sensation you get if you stand up too fast from a chair or from your bed. You feel lightheaded, you feel like you want to pass out. Huge problem because it's a fall risk. In anywhere between, depending on which cardiologist you ask, either very few or about a fifth of people will develop a cough, because it turns out this angiotensin converting enzyme is in the lung, and sometimes the action of the drug has the unfortunate byproduct of stimulating cough in people, and it's a dry, persistent cough. It's super annoying, and usually that's a common reason we end up stopping this medication. The other thing is, by virtue of how it interacts with the kidney, sometimes it can make your kidneys function a little bit worse than usual. Typically your kidneys adjust, and then in the long run it's better for them, but sometimes people, their kidneys just don't like this, and in particular their potassium stays too high, and that's not safe or good. So sometimes if you just can't keep your potassium down, we can't use these medications either. But otherwise they're great meds, great data for them, especially in patients with heart failure, diabetes. We really like to use these if we can. Okay. Now, if we have to stop it because of a cough, we have this other class of drugs called angiotensin receptor blockers. Now, as you might infer from the name, these just work on a different part of the pathway, but have this theoretically the same end effect. For understandable reasons, I guess that's debatable, but for business reasons, pharmaceutical companies don't really like to put these head to head against each other, because they like to be able to market and sell their drug. We know there are differences between the various drugs listed here and between these and ACE inhibitors, but in general, we think they work about as well as the other and are interchangeable. The ones on this, like some of you may be on losartan. Valsartan was recalled last year because of contaminant in batches that came from China. Olmesartan, candesartan, there's some other ones, irbesartan, but the ones we typically see are these, and they have various downsides and upsides in terms of dosing frequency, efficacy, how well they work, things like that. Generally, we don't use both at the same time. In fact, this has been studied in a randomized controlled trial, high quality evidence that showed no benefit. So probably because they do essentially the same thing and there's no additive benefit. So usually won't put people on both. When I see that, I just kind of ask, and typically it's a mistake. Something's been continued, or you're not actually taking both. Same problems though, high potassium, orthostasis. So you have to, sometimes we can't use these just because they don't play nicely with your kidneys. All right, next really common class to start with. These are the calcium channel blockers that end in pene. So nifedipine, amlodipine, not verapamil or diltiazem. Some of you may be on those for atrial fibrillation or fast heart rate. The dihydropyridine part of the chemical is what differentiates two. That's unimportant. All you need to know is that the ones that end in pine are for blood pressure, and they don't affect heart rate, and that's important. These are also good medicines, typically well tolerated, a good first-line agent. The biggest problem these cause, well, two. Leg swelling. They can cause edema because, again, we're dilating vessels, and sometimes that kind of makes them sluggish down in the legs, and you can get edema that can be uncomfortable. That can lead to skin breakdown if they get really bad. So sometimes we can't sort of we can't work around that. And then orthostasis too, that dizzy sensation when you stand up. These are going to do that too because they relax blood vessels. Beta blockers. Now we're moving into drugs that are maybe not so great to start with. Now, when we're using beta blockers to treat blood pressure, and I want to make a distinction here. I'm not talking about beta blockers for people who have atrial fibrillation, or a lot of PVCs, or who have flutter or something like that. I'm talking about beta blockers to treat blood pressure. They work both on the heart by slowing down the heart and making it not squeeze as hard, but that's a smaller part of the effect. Mostly they're working on blood vessels in the same way. They're kind of relaxing them. For blood pressure, we use what are called non-selective. So that's some of you might be on atenolol. Propranolol, not used so much for this anymore, just because you have to take it a lot, and we use it for other things, but not really this. Bisoprolol, I left off labetalol. I should have put that on there. It's a really common one, and that one works pretty well. But not really first-line agents. Atenolol used to be used first-line, but I would argue there are better options than atenolol as a first-line agent, and maybe even atenolol is not always a great option. But if you're looking, if you and your provider are not quite there, and I'll tell you, the average number of drugs people with hypertension end up on is about 3. So so don't despair if you're on 3 meds. You are normal, and that means there's a fair number of people who need 4 or even 5 to get normal, even if they don't have secondary causes. So if you get to that 3rd or 4th option, you're looking for something, that's where these might be helpful. There are some separate data with patients specifically of coronary disease or heart failure, where beta blockers are a good thing for them to be on. At least now, with the state of the evidence we have right now. That may change in 5-10 years, like most things in medicine, but right now, so that might be a reason someone opts to put you on these. Cons, orthostasis, huge problem with these. As monotherapy or so-called single therapy, they just are not as effective as other options. And if you already have the wiring, as I tell my patients, if the wiring in your heart is already kind of wearing out, just with age, called age-related conduction disease, because these can slow down the heart rate, and it can make it worse, and it can actually put your heart into a potentially dangerous rhythm. So for a lot of reasons, these just have a lot more sort of strings attached to them. They're good options when we need them, but we don't like to start with them or even use them 2nd or 3rd. Typically, the ones I started with are your 1st, 2nd, and 3rd or 4th options, and then these are sort of towards the end. So alpha agonists, clonidine is really the one that we're talking about here. And clonidine is really one we see used for resistant hypertension. I usually don't prescribe it as a so-called as needed. Some patients might be on this if their blood pressure is persistently over 180. Not saying there's not a role for that, but I don't like to use clonidine, mainly because orthostasis is a huge problem with clonidine. And if stopped suddenly or not taken regularly, theoretically, it can cause a rebound hypertension much worse than even the high blood pressures you have normally. Now, in reality, that's true of any blood pressure medicine, and clonidine maybe has an unfair reputation of doing this, but it is one of the things that we are concerned about with this medication. It has a unique mechanism of action, really none of the other medications have. And the other thing is, it just doesn't have that extra benefit for patients like with ACE inhibitors with diabetes or beta blockers with heart failure. It's purely a blood pressure lowering agent. Not that that's a bad thing, but we always like to kill 2 birds with 1 stone when we can, and get you as much benefit from the fewest number of drugs possible. One of the nice things about clonidine, if you're using it every day, is it can be used as a patch. So it does cut down on the number of pills that you have to take. You just have to remember to change the patch. Last group I'm going to talk about, because these are just, now we're like way out in the weeds, minoxidil and hydralazine. I lump these together because they are kind of used towards the end of when we're really running out of options. And they really, particularly minoxidil, I never prescribe minoxidil for blood pressure. If the kidney doctors want to do it, go for it. But I don't like to do it. It's a very potent vasodilator, so a lot of orthostasis. Hydralazine too. Hydralazine's, I mean, it's a good drug. I certainly use it, but it has to be dosed 3 times a day, sometimes even 4 times a day. A lot of orthostasis, so a lot of causing dizziness. It's a potent vasodilator, meaning it makes your vessels get big, and that's why it has those side effects. So, and except in certain patient populations, hydralazine doesn't have a lot of added benefit. Although in patients who have really bad heart failure, it's often something we lean on a lot. Okay. No drugs, with drugs, all the things. What are we aiming for? What's our target? How low do we need to get? When I started, medical school, which more than 10 years ago now, we were big on so-called a relaxed or more permissive strategy. So those numbers that Ms. Broom brought up, 130 to 150, fine. We don't even worry about it. And sometimes that's still the case, but we never really studied it. And so fortunately, a few years ago, this thing called the SPRINT trial was done, and it recruited only patients 75 and older, which is huge. That never happens in clinical trials. If you heard me talk about it last weekend, drug companies, to make their stuff look good, often try to find the best, youngest possible candidates who are going to be totally adherent and good taking the medication so they can show a benefit, but that's not really real world. Well, we definitely need more studies of patients who are, in their 8th and 9th and 10th decade of life, because that's who's going to be taking these meds. And what they did is they randomized patients to either the old way, which was, we can relax. 150 is probably as high as we want to go, but it's cool if you're in the 140s. Even if you're in the low 150s, we'll take it. And then the other group got really intensive, trying to get you to 120 over 80. And lo and behold, if in that particular study, and then in these combined studies, it does show a small but real reduction in mortality for patients who shoot for the lower number. 1.5% may not seem like a lot to the individual, and in truth, it's not. But if you apply that to a population of, say, even just 1,000 people, you're talking about hundreds of lives saved, and that's meaningful. So while the number is small, because hypertension is so common, it actually is a huge deal when it comes to preventing excess mortality and morbidity. So what does that mean? Well, talking about orthostasis, basically what I tell my patients is we're going to try to get you as low as we can without causing problems. And the number one problem with blood pressure lowering medications, and this is really medications, this is not diet. Diet, you're probably going to be okay unless you're really dehydrated. But orthostasis. So orthostasis, fundamentally your body, not only does it regulate blood pressure from a minute-to-minute, day-to-day basis, just based on what's going on in you and around you, but changes in position really matters. You might imagine gravity exerts a force on the blood in your body, just as it does everything else on this planet. And when you stand up, gravity works against you. So your body needs a way to react to that, and it does. It increases your heart rate, it squeezes your blood vessels tighter, it makes your heart beat harder to get blood to your brain, to keep you awake and keep you conscious. With aging, even independent of other diseases, this wiring starts to wear out and it starts to slow down, and the sort of the gain on the system starts to give out. And so that means it takes longer to correct blood pressure for positional changes. There's no real way around it. There are medications, quote unquote, for this. They just fundamentally, they work against your blood pressure medicines because they increase salt reabsorption, and that's not what we want to do. So it happens from time to time where I see patients on one of these meds and blood pressure, and that just doesn't make sense. We should tweak your medicines and not put you on more medicines to counteract the effects of the medicines we give you. So the history will just be exactly that. I got up out of bed to use the bathroom. It was 3 o'clock in the morning, and the next thing I knew, I was on the floor. And my, partner, spouse, kid, grandkid, whatever it might be, found me, and I didn't even know. The last thing I remember is getting out of bed and feeling lightheaded. So falls are a huge thing. If you're at my talk this weekend, we talked about fall prevention and frailty as really the one of the primary goals of in geriatric medicine of trying to treat and prevent. And meds obviously can worsen this. If you limit the body's ability to squeeze blood vessels or increase heart rate through any of the medicines we talked about, you can increase the risk or the problem of orthostasis. So it often limits how well we can treat this. And then unfortunately, there are other medical conditions that cause orthostasis. Parkinsonism, which is an umbrella term for Parkinson's disease and its cousins. A huge component of that is this neuropathy or problem with the nerves that control this system that leads to orthostasis. So, and these kinds of problems can really work against you because sometimes your blood pressure, I have a patient who has Parkinson's disease. Sometimes his blood pressure is 200 over 100, and then 10 minutes later, it's 90 over 50. So it adds a whole other layer of complexity to this. With mild cognitive impairment, that's MCI or dementia, you can see these neuropathies as well, leading to orthostasis, heart failure, huge issue, liver failure, like cirrhosis, kidney failure, all these things. So the point is that this is going to be one of the hard stops in terms of trying to get blood pressure low. So we're always trying to balance, trying to keep this at bay, if not non-existent, at least manageable, where, you take a few minutes when you get out of bed to sit and collect yourself before you stand up. That's what we're shooting for. Too many falls, too much orthostasis, not getting enough blood to your brain can increase risk of frailty. I'm not going to go so far to say dementia, but oftentimes people who have blood pressure have vascular changes in their brain that can predispose to dementia or memory loss. But certainly it can increase your frailty if you're falling a lot and hurting yourself. And that's what we're trying to avoid in geriatric medicine. So to round up, how low do we go? We try to get you as low as we can without causing more problems than we're trying to solve. Okay. Saying that I picked up from a surgery attending in med school, and some of you may have heard it, I always like to say is don't let the perfect be the enemy of the good. If we can get to a healthy balance between all these things and have some marginal benefit, that's great. That's better than having all the numbers look perfect and happy. Okay. So in conclusion, blood pressure control is huge and important because it's a common problem that causes a lot of downstream bad things. It starts with your daily habits. It's because these are the things that have wide-ranging efficacy, and they're things that you're going to do no matter what. And if you do them safely, they don't have side effects. Medications are an important part, but we have to make sure we're balancing their good things with their bad things. And in general, the closer we can get you to normal, the better, but not at the expense of increasing falls or orthostasis or, and by extension, frailty or decreased functional status. Okay, so that's the end of my talk, the formal part of my talk. And now hopefully we have some questions and discussion items.
Okay, Claire, go ahead.
Did I miss or did you discuss cholesterol?
Expand on your question.
Well, I mean, how important is it to keep your cholesterol down, and that keeps your blood pressure down, or am I wrong with that?
No, you're right. It's a good question. And again, it points to the complexity of this. Blood pressure and hypertension and cholesterol are sort of form this kind of evil symbiotic relationship. They're like, evil twins or evildoers who work together, because we know, and this is really interesting actually, we know from studies, unfortunately, like from war casualties, particularly the Korean War, there was a big study done of, obviously the young men who were killed in action who were only in their 20s already had evidence of, even in that case, of blood vessel damage from hypertension. Hypertension, just by the stress it puts on the walls of your blood vessels, so-called wall stress, causes damage. Just like your pipes get damaged in your house, the pipes in your body get damaged. These areas of damage have to be repaired by the immune system. A byproduct of that is forming plaque, atherosclerotic plaque, which are, what it sounds like, little chunks of fat and cholesterol and lipids and inflammatory material and other stuff, to be imprecise. And if these get big, they can block vessels, and they can block vessels to your legs and cause pain with walking, and even sometimes cause bad infections if you're not getting enough blood flow. They can cause heart attacks, they can cause strokes, so all those things. So they work together. The worse your blood pressure it is, the faster you're going to lay down plaque. But if you do have higher cholesterol, like LDL in particular, which is a big component of plaques, then you're going to have more vascular disease, which in turn is going to raise your blood pressure because your vessels are narrowing, and then you have hypertension, and it forms this very vicious cycle. So it's actually a really, like, the reason I asked you to expand is it's actually a very, like, important and rich kind of conversation. I would subsume, for the purposes of this talk, cholesterol management really goes with all those lifestyle things we talked about. Some people, because genetically they just make too much low density lipoprotein and too much cholesterol in their liver, have to go on medicines, but generally we'd like to treat cholesterol based on the guidelines for treating cholesterol while we're treating blood pressure, because they do work hand in hand.
Thank you.
Okay, we have a question in the chat. Are beta blockers also effective in treating migraines?
Yes, they are. That's one of the, in fact, propranolol is kind of the go-to as a first line. And to be fair, the calcium channel blockers that I didn't talk about, diltiazem, verapamil, also are. It's through their effect on blood vessels, but for a totally different goal. But yes, a lot of times for my patients who have chronic daily migraine or migraine more than every other day, if I think they'll tolerate it, I'll put them on propranolol, a low dose, and sort of turn it up as high as it can go, essentially. So that's one of the non-hypertension uses for propranolol. And there's no reason, I mean, sometimes you could make the argument that propranolol is just the best studied, but there's no reason to suspect like a metoprolol wouldn't help as much. But typically these days, first line treatment for chronic daily migraine is a beta blocker like propranolol.
Thank you very much, Doctor. It was very informative. I'm sure all of us need to get out there and exercise and eat better. Okay. I'd like to thank you all for coming tonight, and we'll see you next Wednesday.